Generally, in the first infusion, we see about a 43% rate of infusion-related reactions with these patients. So it's important to note it's with the first infusion. So again, this is why patients, we follow a strict protocol, and there are the required pre and post medications of hypersensitivity, so we try to prevent these reactions. And because it's 43% with the daratumumab, in our institute, we have really initiated a new type of protocol. And so 4 hours into the daratumumab infusion, what we'll do is stop the infusion and then administer, again, antihypertensive medications. We'll give patients methylprednisone, we'll give them diphenhydramine, we'll again administer acetaminophen. And by doing that halfway through the infusion, we have seen a major decrease in infusion-related reactions for these patients. So it's really worked out well, our regimen of treating these patients. So again, it's really important to note it's generally with the first infusion, it gets less over time. The first infusion of daratumumab is generally a very long infusion. It can go up to almost 8 hours because we infuse this in a stepwise fashion of patients receiving the drug at 50 milliliters an hour. And if patients do well, then in a stepwise fashion, we can increase that. We don't go any higher than 200 milliliters an hour for those patients. Just also important to note, if a patient is having a reaction, the nurse would stop the infusion, administer antihypertensive medications, and once those infusion-related reactions have resolved, they can, again, reinitiate therapy, but again, at the lower rate of 50 milliliters an hour.
So at our center, when we have an infusion reaction to daratumumab, first thing you want to do is grade it. Grading using the CTCAE scale. If you have a grade 1, which is a mild reaction, we may just want to slow it down, possibly stop it. Certainly if you have a higher grade reaction, grade 2, grade 3, we're absolutely going to stop it and manage it appropriately. We're going to be looking for signs of an infusion reaction, stopping that, and then managing it appropriately.
How we manage mild daratumumab reactions are to assess the patient. If they're really not having much discomfort, we know they've already had those pre-medications. Typically, we can push through. If it's more of a grade 2 or grade 3 type reaction, then we'll stop the infusion per protocol, give them additional medications, and then resume the infusion. We also have a nurse practitioner who's stationed in our infusion center, so she's available to see these patients if needed immediately.
As I talked about earlier, generally it's with the first infusion of daratumumab do we see more severe infusion-related reactions, and then after that first infusion becomes less and less. Patients can still have a milder infusion reaction, but still, I will tell you that we adhere very strictly to a protocol administering steroids and antihypertensive medications, the H1, H2 blockers, 24 to 48 hours pre and post infusion. And this, again, by giving these medications to the patient, it mitigates mild or severe infusion-related reactions. So pre-medications are required at our institute. We have instituted a protocol for all patients when they're receiving monoclonal antibodies that have known infusion-related reactions. So for example, our patients are required 2 days before they're coming in for their first infusion to receive 2 days of methylprednisone along with an H1 and H2 antihistamine blockers. That goes the same for post-infusion. They still receive 2 days of methylprednisone along with an H1, H2 blocker. It could be diphenhydramine or any of the other, antihistamine blockers. I should say, and of course, on the day of infusion, on the day of the daratumumab infusion, patients also receive more methylprednisone along with higher doses of diphenhydramine. They receive 1,000 milligrams of acetaminophen. Again, what's important to note is recommendations for pre-medications are in the package insert of all the monoclonal antibodies, but every institute is different with a protocol for their pre and post medications.
At our center for pre-medications for myeloma, for the monoclonal antibodies, we give a corticosteroid, we give acetaminophen and antihistamine, and we also give montelukast. We found that when we added that, in addition to the other pre-meds, by giving it at least an hour prior to the infusion to the patient, we saw far less severity in reactions. We still saw close to 50% reactions for daratumumab, but the severity was much less. So we've made that part of our protocol to add, as have many other centers now.
So pre-medications at our center, we give, they have their oral medication that they take before they come in, and then we also give intravenous dexamethasone as well. We give intravenous Benadryl and oral Tylenol.